Hey everyone, Steve Arndt, orthopedic foot and ankle surgeon at Southeast Orthopedic Specialists. We're here to talk a little bit about common causes of foot and ankle pain and some of the minimally invasive procedures to fix them. A little background on me, from Chicago, moved down here a couple years ago. I actually trained down here in my residency, and then I did a fellowship in foot and ankle surgery in orthopedics at Cleveland Clinic, and then was in Chicago. Ultimately, decided to move back down here. A good decision, and so hopefully you guys will get something out of this talk. I kind of wanted to hit on a handful of topics I see commonly, and just really hit on some of the topics that, one, I see a lot, that people ask a lot of questions about, and two, people are asking a lot about, is there a minimally invasive technique? Is there an arthroscopic technique? And maybe clear some of that up and hopefully offer some options for some of these problems that do exist. So, minimally invasive doesn't mean a poke hole. It doesn't mean everything is done without an incision or a laser or arthroscopically. It really means doing the most effective surgery that we can do through really the smallest incision possible. And kind of thinking about how can we do the same procedure with less exposure or percutaneous, or do we need to dissect that much, or what's the absolute amount of exposure that we need to really still accomplish the surgical goals that we want to accomplish. That's really the main part. We don't want to cheat or shortcut what we're trying to do, but if we can do it in a way that involves less incision, less exposure, less dissection, that's really valuable, especially in the foot and ankle. So arthroscopically typically refers to the camera poke hole incision to evaluate a joint, and minimally invasively is really more small incisions, percutaneous approaches to other areas that arthroscopy would be challenging. I always put in, kind of from my perspective, it's harder to learn. There's a large learning curve for it, because you're not looking at things directly. And so there's three-dimensional and two-dimensional kind of things you have to think about. But in the end, if you can do enough and get proficient at it, it really probably does save time. There's no increase in cost. There's no increase in reimbursement. It's just really a different way to do things. And a lot of it relies on some special instrumentation that kind of allows us to do those things. I think the big advantage is really from the patient perspective. And in the foot and ankle, really, I think wound complications can't be emphasized enough. I tell everyone, I think foot and ankle orthopedic surgery would really be pretty easy if the skin healed in a day, but it doesn't. And so a lot of the problems we run into are just waiting on the skin to heal. And a lot of our recovery is really based on when the skin heals. Most of the time, I rarely base the time to weight bearing or time to the foot hitting the ground on the actual bony work that we do. I really mostly base it on when is the wound healed, when do I think the swelling's down, when's the skin healing. So this really can be advantageous when you're thinking about faster recovery in a lot of the common areas and problems we might see in the foot and ankle. So I'm going to kind of touch on a couple common ones that I see a lot. So Achilles tendon problems, plantar fascia problems, flat feet, and really bunions. And I think minimally invasive techniques in each one of these really has a pretty good role. I think the only one that can't be completely solved by it is the flat foot, but I think that even that's got a pretty good kind of newer technique that involves some pretty cool minimally invasive approaches. So bunions, and I'm not going to spend a lot of time going through exactly what it is, but essentially, bunion really means any enlargement over that, big toe joint. Hallux valgus, which has kind of become synonymous with bunions, is sort of referencing the lateral position of the toe relative to the metatarsal. And so most of the time, it's not just a bump, a growth. We can't take it off or shave it off. It's really your normal metatarsal head, a normal, toe joint, just in an abnormal position where certain parts that aren't supposed to be exposed are exposed. And so what we try to think about is how do we, straighten that out? How do we fix that? In when we look at it on X-ray, and X-ray is probably critical, and we look at it when we're standing because the foot changes position when we stand, we see that the toe can rotate and shift and move. And so, that's another challenge of foot and ankle surgery is when we're doing surgery, we're obviously not having the patient weight bear. And so if we try to, we have to try to simulate weight bearing and what the foot will look like when it's weight bearing in a non-weight bearing position. Now we have tricks to do that, but that's really what we're trying to kind of simulate is what's your foot going to look like when you're walking. And so that's what we're recreating. And that's why weight bearing x-rays are so valuable. I'll kind of say the same thing about bunions that I tell everyone. Conservative treatment is excellent and it can work really well. Wide shoes, changing your shoes, any kind of splints, pads, spacers, these can be effective at relieving pain. They can sometimes slow down the progression. They're not going to change the natural history of it. They're not going to straighten out the bunion. They're not going to make a toe that has a bunion not have a bunion anymore. So they're of value. Shoe wear's of value. Ice and anti-inflammatories. You can do cortisone injections for pain. These are all things to help with the symptoms. But as I tell people, there's no non-surgical cure for a bunion. And so most of the time what it kind of involves, and I kind of use this with most things in kind of the foot and ankle world, live with it and tolerate it until you can't. I can always fix a bunion, whether it's now or in 10 years. The only thing I tell people is if it's in 10 years, the procedure you might have to do might be a little different. The angles might get a little bigger. It might involve the second toe or the third toe. But long story short, if you have a bunion and you're doing really, really well, I would leave it alone. If it's starting to hurt, it's making shoe wear difficult. It's starting to become one of those things where it's interfering with what you want to do. It's starting to upset your normal activities if going to the grocery store is becoming a very annoying and painful thing because of it. These are times you start to think about, okay, maybe it is time. Maybe I don't want to do something about it. And I think that, to me, minimally invasive bunion surgery is probably one of the coolest and newest techniques we have for it. And, open bunion surgery works well. And there's a number of ways to fix a bunion, and you can make an incision. When you have an incision, you have to wait for the wound to heal, usually to weight bear. It delays your weight bearing. It's a longer surgical recovery. And so even though from a bone standpoint, and there's a procedure I do that's advertised a lot and has a lot of direct kind of patient marketing called the Lapiplasty, and I do them. And I like them. And what I tell people is it's a good procedure, but it involves a lot of precision, a lot of incisions, a lot of wound dissection. And so, in the Lapiplasty marketing, they kind of say, well, we're stable enough to walk immediately. And that's true. They've done some biomechanical testing. But when you weight bear immediately, there's so much swelling and there's so much pressure on the wound that the skin will pop open, the sutures will pop, and then you have to wait for the skin to heal from the bottom up. And that takes a lot of time and it's a lot of delay. And so it's kind of one of those things where we don't delay, like I said, because of bone, we delay because of skin. And so if we can do a bunion that spares soft tissue dissection, it doesn't strip the skin, it's just poke hole incisions, we can do really early weight bearing. We can have very quick wound healing. And I'll kind of show a couple examples of x-rays of what I'm talking about, and hopefully it'll kind of make sense. So What minimally invasive does is it makes a series of cuts within the bone that ultimately gets the toe to look straight. And I'll show some angles that I hope make some sense. The two types of cuts I make, one is in the metatarsal bone at the end of it, and then one is in the proximal phalanx, so on both sides of the big toe joint. And we make cuts in both of those bones, and we hold them in place with screws to align it. So if we look at this x-ray, this is a mild bunion, and I've drawn some lines. And on the left, the 9.9 or 10 degrees, that's the intermetatarsal angle. So that's kind of what we think causes the bunion, right? So the intuitive approach would say, well, if you just make that 0, you'll be good. And to some extent that's true, and that's what the Lapidus and Lapiplasty aims to do. But we talked about that, big incisions, a lot of incisions, could be potentially delayed wound healing. And then we look at this angle. This is kind of our hallux valgus angle to some extent, right? This 34.6, that's kind of where the toe's pointing relative to the metatarsal. So our goal is really to get that 34.6 as close to 0 as possible. 0 to 5 is kind of a normal reference range. And our goal on that 9.9 is to get that number to as close to 0 as possible. And we think that gives a pretty good bunion outcome. And so I'm going to show the x-ray of what minimally invasive looks, and then I'll show the skin incision. So as you can see, we've made a series of cuts in the bone, but those same lines I drew now have much lower numbers, 0.7 and 2.3. So we've taken the bunion, and if you look at that, that bone is straight. It will visually look straight. We've just kind of done it in a zigzag sort of roundabout way through really small skin incisions. And if you look on that, it's a little blurry, but that's the traditional minimally invasive involves maybe 1 or 2 cuts. There's just some poke holes on that one. There's kind of 3 poke holes along the side. 1 to make your cut, 2 to put the screws in, and there's 1 on the other side of that toe where we do our cut and screw. So really small incisions to get a really nice looking straight toe. I generally have people 2 weeks in a post-op shoe. We can heal weight bear pretty much immediately. There's no special elevate all the time, ice all the time. After the 2 weeks in the post-op shoe, it's full weight bearing still in that post-op shoe. My goal is at 4 weeks to go into a normal shoe. There will still be swelling. And so I always tell patients, don't get met. I will let you get into a regular shoe at 4 weeks, but don't get mad at me if you can't, because it's still a little swollen. And then hopefully at 8 weeks, if enough healing is seen on x-ray, which is common, we'll start to progress to light jogging and running and really advance. And so, this enables us a really fast recovery in what was once a pretty long recovery. And a lot of it is because of, 2 things. 1, stable fixation. And we get that with those screws. And 2 is we don't really have to worry too much about the skin healing. There's no wound dehiscence in a poke hole incision like that. And so where this is really effective is 1, for fast recovery, but 2, anyone with a healing issue. The foot doesn't get great blood flow, and so we know there's slower healing. So people with diabetes, albeit you still want controlled diabetes, but these are good options for that, or any kind of maybe sluggish blood flow, good options for that. And just in general, a fast weight bearing. So I think this has really become a pretty cool procedure from that end in terms of how we can do a bunion minimally invasively, good recovery, straight toe, and the risk of recurrence is really low. It's about 5%. And even in that 5%, it still only recurs a couple degrees. If you remember that angle that was 34.6, it might go back to 10 degrees. Yes, slight curve, but that 5% nowhere near what it was. So I think a very good option for these cases. Next thing I'll talk about a little bit is plantar fascia. So, another really common topic. We know the plantar fascia maintains our arch. It's related to our calf. It's related to the Achilles tendon. It's a common cause of heel pain. We see it at the medial heel. 50% of people will have bone spurs related to it. The spurs are related, but typically this isn't an area where we have to remove bone spurs. So most of the time, this is an area we can treat non-surgically. So the classic approach is morning pain. Once they get going, it eases up. It's at the medial plantar heel, increases with activity. Just being out of shape and overweight can certainly contribute to this and more stress to it. And it's really pain on sort of the bottom of the heel. So conservative treatment works in 95% of cases. The issue here is it just lasts a very long time, potentially up to 12 months. I've listed a lot of things. I have a pretty specific regimen. I usually start with kind of freezing a water bottle and having you roll it over a frozen water bottle. We'll do calf and Achilles stretching. We'll do plantar fascia stretching, and stretching is the hallmark. The thought is the looser the calf, the looser the Achilles tendon, the looser the plantar fascia, the looser something is, the less painful it is when you walk on it. Think about something that's gotten really tight, and all of a sudden when you step down, it very acutely stretches. It's very painful. And then as you get going and it stays on stretch, it gets less painful. So if we can keep it stretched, it's just less painful. Cortisone shots are really a good option here. They can weaken the plantar fascia, but rarely does that happen. They can weaken some of the fat pad. Again, rarely does that happen. So most of the time they're safe. They're an effective way to take down inflammation within the plantar fascia. So rarely are you having to do an open release. There is a full open release that's, 4 or 5 centimeters, almost never done. There's a mini open release, and then there's a percutaneous tenotomy. Company called 10X happens to make. Can be done with a local anesthetic. It's a poke hole incision. It has ultrasonic and radio frequency waves that break up the tendon tissue or the plantar fascia tissue. And it really only takes about 5 minutes. Weight bearing in a boot post-operatively. So that's an option. That procedure is about 85% successful at 6 weeks. It's often done in conjunction with PRP. It's usually done at the hospital because the hospital has the machine that we can do it. If that doesn't work, you can move to a mini open approach, which is typically this incision here, one or two small sutures. We release 80% of the plantar fascia. In this one, you're non-weight bearing, splinted for 2 weeks. And the goal of that is you don't want the plantar fascia to reattach. Then you weight bear in a boot for 2 weeks. We start transitioning to a shoe. Both are going to involve some physical therapy, and both have good options, good small incision options. Typically, though, I'll wait honestly around 6 months of symptoms before we do this, because I do think that most of the time plantar fascia symptoms get better within about 6 months. So in this kind of whirlwind of foot and ankle topics, this is going to be flat feet, very common. And I think flat feet, when you think about it from a patient perspective, one, you can look down and say, I don't have an arch or I have flat foot. Where is the pain and why is there pain from that? All right. So it's really this posterior tibial tendon on the inside part of the foot causes a lot of pain. It's inflamed, it's aggravated, it's irritated. Okay. And then the other reason there's pain is there's an actual change in the position of your foot. It's flat. And so oftentimes, even with medial pain or in the absence of medial pain, there'll be pain on the outside part of the ankle, or kind of that anterior ankle, anterior lateral ankle. And that's because of what's called impingement, where tissue is pinching by the fibula. So the posterior tibial tendon's goal is to help maintain our arch, and it inserts on the medial side of our foot. And this is kind of how it courses. And so kind of around that bone on the inside, that medial malleolus, is commonly this posterior tibial tendon pain. And what I always say is it's kind of a chicken and egg phenomenon. As the foot goes flatter, there's more stretch, more strain on the tendon. The tendon then weakens and tears more. If the tendon's job is to help maintain our arch and it's now weaker and tearing more, the foot will go flatter. And then it goes to get more stress on the tendon, and so on and so forth. And so we have to stop that cycle somehow. In one of the ways, and we kind of think about doing that, is, you look at the foot, and the main thing we're really looking at when we see this is what's the position of the heel. And so when I think about this, I look at the patient from the behind, and we'll look down at the heel, and we'll basically see where it is. And I think I have a picture coming up of exactly what that might look like. So on this view here, you can kind of see that the heel is going out, especially on that one on the left. That's a classic hindfoot valgus, pes planus type of picture. So that's kind of the main view we want to see. We also want to get an x-ray, right? An x-ray here is going to show the foot's flat. It's going to show that that forefoot is abducted or pronated in a lot of cases. And that's kind of what we're looking to kind of address. And so when we think about how do we manage this, there's two ways to manage it. And there's kind of two competing pathways. The first is let's help support the tendon. If we support the tendon will have to work less. It'll be less inflamed. So this is where inserts, arch supports, shoe wear, shoes with thick soles, shoes with thick, stiff soles, bracing, all come into play. And then how do we decrease inflammation? Ice, anti-inflammatories. If the pain is anterior or anterolateral, we'll commonly give a cortisone shot to decrease synovitis. Medial pain, you can give a cortisone injection to the posterior tibial tendon. It's not something you want to do a lot of, as it can cause the tendon to weaken and rupture. But basically, when we think about it, we think about, I want to structurally support the foot, and I want to decrease the inflammation in the tendon inside of the foot. And these are a couple examples of the braces, and they are to some extent cumbersome because the tendon controls both the ankle and the foot. And so we're trying to control for both of those. When we look at surgery, there's a number of surgical options, and I'm really going to focus on the second stage because that's the most common stage. It's kind of before we get very arthritic, but while we already have a little bit of a flat foot. So the kind of average flat foot, pain medial, pain laterally, what can we do? And there's two things we think about. The first is we cut and move the heel. So if you remember from that picture where the heel was very far off to the outside part, we want to get that lined up with the tibia or lined up with the leg. We do that by cutting it. That historically was a very high incidence of skin incision and a very hard area to get to heal. So that is an area we can actually now do minimally invasively, which is sped up again, this whole recovery and healing process, because that wound is no longer an issue. And I'll show some pictures of that. And then on the inside, we clean up the tendon and we transfer another tendon to help aid it. And so we're kind of strengthening the inside. So if you think of a flat foot, I'm tensioning the inside and I'm moving that heel over to support it. The calcaneus part really was a delayed healing and was a big skin incision problem. And so, you know, it caused people to kind of not want to do the surgery as much because, quite honestly, if you're waiting for that wound to heal, you're going to be off of it for sometimes 6 weeks. And now that we can do that percutaneously and minimally invasively, we still got to keep you off of it. And it's usually a few weeks, but it's a lot quicker than it was. And it involves, you know, this is kind of what the heel osteotomy looks like, but we make a poke hole on the left. We use a burr to cut the heel. We slide it medially, and then we put a couple screws in it to hold it in place. And we really do it all through that incision. So there's one incision here on the side, and then one kind of in the back. And that's that's the whole osteotomy portion. So there's no skin incision, there's no healing, there's good stable fixation. And what we know about good stable fixation and no skin problems is we can weight bear earlier. Now we are going to have about a 3 centimeter incision on the medial side. We can't really debride the tendon, transfer a tendon yet, arthroscopically or minimally invasively. I'm not saying we won't be able to, but at least at this point in time, you know, we're not able to do it. But in general, you know, as a summary to flat foot, whether it's surgical or non-surgical, our goals are the same. I need to support your arch, I need to support your tendon, and I need to decrease your inflammation. And that's kind of the goals of flat foot. The last topic I'll hit on, I think, is like the bunion, probably the coolest minimally invasive approach that's out there. And it's really for kind of Haglund's deformity, calcaneal spurs, Achilles tendonitis, all kind of in that same spectrum, but basically pain at the back of the heel, pain where the Achilles meets the calcaneus bone. You'll see a bump. It's painful. Could be Haglund's, calcaneus, bursitis, spur, basically inflammation of that tendon at that insertion. You'll a lot of times see that bump in the back, or you'll see the spur, and that's both calcification, that's both spur, and that's usually both bursa all in one. So a lot of times if you look down and you see a bump, it's going to be spur, calcification, bursa, thickened tendon. It's kind of a combination of everything back there. And so same concept with kind of, plantar fascia. It's often older, getting active, or doing a lot of hill running. You're doing a lot of walking on the beach, and so your foot's digging in. That all exacerbates the Achilles tendon. And so we see spurs in the back, we see bony prominences in the back. And our goal, these spurs dig up into the Achilles tendon. So they're painful for a couple of reasons. One, bone spurs are painful. Two, spurs that dig up into the Achilles tendon are painful. And so every time you walk and you have a spur, it hurts. Conservative management in this is probably not as successful as we'd like it to be, because no matter what we might do, if there's a spur, that's still going to be there. You could stretch and ice, anti-inflammatories. We don't give cortisone shots here because it can rupture the tendon, and that is a big problem. Symptoms that are kind of present for 3 to 6 months typically fail non-surgical management. So historically, we would make a big open skin incision, detach the Achilles tendon, saw off the back end of the calcaneus, and reattach the Achilles tendon. Long recovery, a lot of wound complications, to the point where people were kind of not doing it. And then guys were kind of like, well, maybe we can do this without that big incision. And so we kind of thought, how can we do this where maybe we don't have to detach the tendon? Maybe we could get some early range of motion, early weight bearing, faster recovery. And so, the equipment was developed, and it's technically challenging, but a really satisfying procedure because the recovery is very quick relative to what it once was, and the incidence of complications is much lower. These wounds will still break down, but at a much lower pace. And I'll show you some of the skin incisions that we use. So I haven't done an open, Achilles spur resection detachment, unless it's a revision in years. I do all of them kind of arthroscopically or minimally invasive. And so you often put a camera in to evaluate the Achilles tendon, debride the Achilles tendon. And then with X-ray, you'll do your work to debride the skin incision. So from the standpoint of kind of recovery, and I'll show some pictures, but week 0 to 1 is a splint non-weight bearing. Then we go into a boot with some lifts, begin weight bearing as comfort allows. 3 weeks sutures are out. We're kind of that time transitioning. In that 3 to 6 weeks, we start the process of weaning from the boot to a shoe. The hope is at 6 weeks, we're in a shoe and strengthening. And then, Achilles tendon surgery, even though at 6 weeks, the goal is in a shoe and strengthening, it still is going to take 3 to 6 months to kind of feel where you want to feel. So we identify kind of the spur, and we identify the back prominence of the calcaneus on X-ray. We'll make a stab incision. We kind of do our work through X-ray to sort of remove all of our spurring, all of our calcification. So this is a high-speed burr with suction and a water pump on it as well to kind of debride and irrigate. We then place anchors, because inevitably when you take that spur out, there's a void in the tendon. And when you decompress the bone, there's a little laxity in the tendon. Although it's not been decompressed, you still have to get bone out of the tendon. And so we essentially take these sutures and anchor it down. Those are the only pokes, though, that you see, those 3 incisions. And then, spurs gone, it's decompressed. And basically, you've taken what was once a really large, long posterior incision in an area that's hard to heal. And, sometimes I'll do this in just 3 poke holes. Sometimes it's 5, sometimes it's 4, sometimes it's 2, just depending on what's needed. But this has been really a neat sort of way to use a minimally invasive technique in my practice. So that's probably enough foot and ankle topics for me to go through, but I'm happy to take any questions that may exist. So, a couple things there. Neuropathy, certainly an option. And then obviously spinal stenosis can cause nerve problems in the foot. So if there's a history of spinal stenosis, that may be a reversible problem with neuropathy. So there's kind of two theories on neuropathy, and I won't, because it's a complicated topic, but there's kind of the neuropathy with diabetes, neuropathy, we don't know what causes it, neuropathy. That's tough. There's no great cure for that. We have some medications, we have some physical therapy modalities, some topical creams that we can certainly try to make it better, but often it's not a go away mentality. Now, neuropathy that we sometimes can make a difference in is if it is from the low back or spinal stenosis or a pinched nerve, or if you did have a surgery before and we think it's a specific entrapment. With total ankles, generally speaking, the incisions in the front, so symptoms of nerve symptoms on the bottom of the foot are probably not due to that. It sounds more like neuropathy, but I would be interested to see what the back workup was or what the spinal stenosis workup was there, because that could be a reversible cause of the neuropathy, in my opinion. So I do treat that. It's very common. I'm sorry you have it because it's super annoying. So accessory navicular, it's a bone in the medial part of the foot, and it's essentially like an extra bone. The posterior tibial tendon, which we talked a little bit about earlier, inserts there. Once the brain kind of is aware that there's this extra bone, it's really, really hard to turn off. And so from a non-surgical standpoint, it's really challenging. The concept of non-surgical modalities here is similar to what it is in a flat foot. If we can support and relax the tendon, insert in braces, that may help. Ice, anti-inflammatories could be an option. A one-time cortisone shot to decrease inflammation could be an option. Basically, support the foot, decrease inflammation. From a surgical standpoint, I'll tell you my protocol. I did 2 surgeries on the accessory navicular today. It's probably similar to what you had done 20 years ago, truthfully. You shell, hopefully you can make a 2 or 3 centimeter incision. You shell out the accessory navicular bone from the posterior tibial tendon, and then you kind of retension the tendon onto the bone. Typically no weight for the first 2 to 3 weeks, walking in a boot, hopefully for the next 3 to 4 weeks after that, and then transition to a shoe. Probably similar to what was done, and unfortunately still kind of the mainstay, but happy to see, and I definitely treat that all the time. So I think I like stem cell injections. I like PRP injections. I think it's not super well, the reason that I never over promote it is 2 things. One, it's cash pay and it's not cheap. Either route, whether you do a stem cell injection or you take your own bloods and spin it down to growth factors. 2, insurances don't cover it. And the reason insurances don't cover it are twofold. 1, it's not cheap. And 2, the literature is just it's not great. It's definitely positive in the sense that it does improve the symptoms, and it absolutely can cause healing and promote healing. It just probably doesn't do it at a great enough percentage to make it a routine part of treatment. Like if you had a study where you had 100 partial Achilles tears and you gave a stem cell injection and all 100 healed, you'd have a no-brainer. We don't have that. It might be 70%, 30% still don't or stay symptomatic. So I try to present the options. I do think it works. I think it's valuable to do. You do have to be prepared, though, that it might not work. There's no downside to do it other than the cost. And there is a lot of upside, and it can be a really good way to avoid surgery. When it comes to arthritis, it's a little different. With a tendon, it can heal it. And I think you have a lot better chance with a tendon to do that. With arthritis, what a stem cell injection or a PRP injection is doing is it's really modulating your immune response to the arthritis. So if I give a stem cell injection, I can't change the bone on bone. I will not regrow the cartilage. I will not create a joint space. And I know people advertise that and they say that, but that really just doesn't happen. But what it can do is it can change the way your body responds to it. So if we think about arthritis, bone rubs on bone, it creates inflammation. That inflammation sends markers to your brain. Your brain perceives those markers and then says, "Oh man, that's not normal. We're going to send our pain soldiers over there," and it hurts. Well, PRP can change the way, or stem cells can change the way your body responds to that. So it may not change that you have bone on bone, but it may not create that same level of inflammation. It may not send those same signals to your brain, in which case you're not having any symptoms, and it can last for really long periods of time. And so I do think there's value, as long as you understand it's not a cure. That's the key component for that. Whereas with a partial tendon injury, it actually might cure it. With arthritis, it's going to probably change the symptoms, change the way you respond to it, and it could be for a really long time. And it may prevent the cartilage that's already there from degrading more. It may keep things that are in there already healthy, for sure, but it's not going to probably regrow broad areas of cartilage. So they can be effective to slow the progression. They're not really effective at correcting it. So they can't make the toe go straight. However, we do know they can create some pain relief. And if it, sometimes the bunions hurt because it's in a shoe and it's rubbing on certain areas. And so if the splint changes the way that, the toe sits in the shoe, it can be effective for pain relief. And it can, in theory, be effective at slowing down the progression. We know bunions all get bigger, and we know they get bigger with time. And so if you do something that's potentially preventing that bunion, or you're not wearing tight shoes, or you're doing a splint, you're probably not going to ever get it straight. You're not going to change its position. If you take the splint off, it'll look the same, but you may prevent it or slow down its acceleration. So bumps on the top of the feet most commonly are bone spurs. I wouldn't say they're always bone spurs, but most commonly can be bone spurs from midfoot arthritis. So if we think about arthritis, bones rub together, it creates bone spurring. That spurring rubs on tendons and nerves. That's an area where you can try a cortisone shot. We'd probably get an x-ray to confirm it's a bone spur. It could be a ganglion cyst or soft tissue, but I'm going to go with bone spur for now. But we would say we get an x-ray, we could do a cortisone shot. That's one way to help decrease it. Spurs are actually a pretty good way now. We can do minimally invasively get rid of. So make a poke hole, shave them down. So there's a couple options, depending on what's causing the bump. There's a couple options that exist. Yeah, so that's a great question, actually. So everyone talks about flat feet, and that's obviously much more common than high arches. But high arches, the biggest problem with high arches are it shifts weight to the outside part of the foot, and the outside part of the foot has smaller bones. The fibula bone in the leg is a smaller bone, and so the problems with high arches can be instability of the ankle and pain on the outside part of the foot because of abnormal stresses, and then you're usually more prone to actually plantar fascia too, because the plantar fascia is tighter. So like tight calves, tight plantar fascia, pain on the outside part of the foot, pain on the outside part of the ankle are kind of the mainstays. And then occasionally even ankle instability if it's a really high arch. So yes to that, and there are a couple of wound care doctors in the area that will do that. And similar to the PRP, the stem cell, there's pretty good literature to support it. It's usually not insurance covered, but absolutely that can be used. Screws can be a number of materials. Most commonly in the foot and ankle are going to be titanium. In other parts of the body, they can be stainless steel, but most of the time in the foot and ankle, I'd say 95 times out of 100, you're going to have a titanium screw. Sure. So hypermobility and ankle instability to some extent go hand in hand. If it's hypermobile joints, it's a little trickier. So the traditional approach to ankle instability would be, non-surgically bracing, physical therapy, supportive shoes, and hopefully providing support. If we get to a surgical standpoint, we're relying to some extent on your tissue. And so we'll tension and repair the lateral ligaments to the fibula bone. And oftentimes we'll take it's called the extensor retinaculum, we'll augment with some more tissue in there. And even a lot of times after that, we'll even put a strip of, we call it suture tape or fiber tape. So we're basically retensioning everything on the outside part of the ankle. In hypermobility, if it's true hypermobility, a lot of times the tissue, the soft tissue, the quality of the tissue is not good. And so if it's really bad and you don't think that there's anything of the patient's own tissue that's qualifies to repair, and that rarely happens, I would point out, you can use mesh, which will incorporate a lot of times. So kind of like hernia mesh, but in thin strips. We have the suture tape mentioned before. So we'll always take some version of the tissue, but we may use more augmented like anchors, tapes, meshes. If it's really bad, there's absolutely nothing there. You can take usually it's cadaver tendon and kind of weave it through and create the ligaments that way. So we've got a couple options. Most of the time it doesn't get to that point, but there's options for every level of kind of tissue quality, so to speak. All right, guys, thanks very much. I appreciate everyone tuning in. Great questions. I've done a lot of these. I thought these were probably the best questions I've had. So thanks for listening. Thanks for asking. And hopefully you learned something. Anything that in the foot and ankle, I do all of it, not just those 4 topics. So anything that you might want to have a question about or see me for, I'm happy to see you. And I hang out in Riverside, Ponte Vedra, and our Center 1 location. So hopefully if something comes up in the foot and ankle, common or uncommon, I'm happy to see you for it. Thank you.